All right, so tonight's basically is a big review over CPR. It's a BLS resuscitation. These are the things that we're going to go over, and then for the ones that don't have the CPR, um, when you get to the boot camp, man, I'm already yawning. What is the deal? So when you get to boot camp, you'll be able to do your required skills, and you can get the certification out, like Robert spoke to you, some of you about. So we'll be able to get that there. Um, so over throughout the night, it's not. I mean, CPR, it don't get really any easier. I mean, it can get difficult. And trust me, I've done this multiple times in different places that I could ever choose never to do it again. But it is what it is. So shock and resuscitation applies the fundamental knowledge of cause, pathophysiology, and management of shock, respiratory failure or arrest, cardiac failure or arrest, and post-resuscitation management. So every bit of CPR, if you don't give adequate, chest rise and fall, as in with pumps, compression pumps, where'd that come from? And then if you don't give adequate breaths, bag valve mask, you don't have a good seal, all these combine together for good resuscitation. They're all important, just as important as possible. Basic BLS, basic life support and CPR and all that was funded in the 1960s, started around then. I promise you, you're going to want to know that because that's going to be a question. You have specific techniques. It's been reviewed and revised regularly. CPR it's updated. I don't want to say it's updated all the time. I don't want to say that it's reviewed, but there's constantly peer reviews and different updates that are put out there for the community boards to read, to potential look at, and the paths that are going to be changing. A lot of your ambulance services in the Northwest, big Metro 1 in Seattle is a big one. Miami-Dade's a big one. They check all these places and they give them like, hey, we're going to do a study of 500 patients from your area of no ventilation CPR. And then we're going to do another 500 in this area with no compression CPR. And that's where they get their changes and their data from, is just in the field. That's a lot of the stuff that they see. So elements of basic life support, non-invasive emergency life-saving care. Let me tell you, every bit of it is evasive, unless you just transporting Granny back and forth to Dallas. I promise you, at some point in time and change, if it's gonna change, and you're gonna have to do some wild, crazy stuff in the middle of like a ditch upside down, and the patient hung in with their car, and you gotta have to be extricated. It's crazy. Every bit of it is invasive. I mean, it's rough. Sometimes you sit back and you wonder, be like, oh my God, I am wore out. But we're gonna talk about airway obstructions, respiratory arrest, cardiac arrest. Those are the big things that are super important we know to make sure to do. You always want to focus on your ABCs. Sometimes they can be CAB because of if it's circulation, if their bleeding is major, they need to fix the CAB in the first part. You've seen that in some of your other lectures. But ABCs was formed, and that's the way they initially wanted you to do it, no matter what, back in the day, where you did airway, breathing, circulation. Any part of that had to do with obstructions, clearing the airway. Then you went to respiratory rest. If you noticed they weren't breathing, you automatically went to start bagging. You just started bagging the patient. And then circulatory, cardiac arrest and severe bleeding. Stop the bleeding. Back to it again. If you see that, and that's the first thing you come across, is stop it, put your hand on it, do something to where we as providers know when you're doing your skills, be like, oh, maybe they do know what they're doing. Okay, let's watch them. Let's see how they do, and we will leave you alone. Ideal, only the second should pass between the time you recognize a patient needs BLS and the start of treatment. Permanent brain damage is possible of brain without oxygen 4 to 6 minutes. So you should be able to get, well, let's look at this one. All right, so right here you have, this is your critical clock. 0 to 1 minutes cardiac irritability, 0 to 4 you start noticing brain damage, 4 to 6 So brain damage is not likely. 4 to 6 is brain damage is possible. 6 to 10 is brain damage is very likely, and greater than 10 minutes is irreversible brain damage. So basically, greater 10 minutes, you start losing 10% of your brain functions. So if you're down and unresponsive for 30 minutes, you have lost 30% of your brain functions. So it is important if you recognize that initially and you see that. Oh, let me get some water. And you see that this patient is unresponsive as you're walking up to them, slumped over the wheel, or they're on the floor unresponsive in their house, you recognize that, you know automatically what you need to start doing. Okay, this is turned in from Granny slipped, tripped, and fell to now she's in cardiac arrest. Maybe the cardiac arrest is what caused her to slip, trip, and fall. But no matter what, it's time for you to start doing CPR. Well, that should not take you, I mean, I know it says seconds, but that should not take you seconds, because you realize something's wrong and it's our duty to act and respond. And now you got to do something. So your duty is to do CPR. So the next part is cardiopulmonary resuscitation. That's what CPR stands for. If I didn't know that, I'm sure that they'll break some tests down and all that. Question to get you to say that later on. It reestablishes circulation and artificial ventilations in a patient who is not breathing, has no pulse. Basically, I want you to compress and release the heart. Now, we can't do, intersternum chest, heart compressions. We can't crack the chest and grab the heart and start squeezing it. They just don't allow that in the field. I mean, yeah, it'd be pretty cool, but I don't know if I want to do that. Like, saw your chest open and be like, not me. We good though. But that's that. So CPR, some of your steps is restore circulation, perform chest compressions, open the airway, restore breathing, provide rescue breathing. What are the 2 paths that we can do to open up the airway? Somebody. Oh, let me open up the chat while y'all are talking. I didn't figure y'all would talk, to be honest.
You said, like, what can we do to open up the airway?
That's correct. What are the 2 maneuvers you can use to open up the airway?
The head tilt maneuver and the jaw maneuver.
All right, so the head tilt, chin lift.
Yeah.
And the jaw thrust. Okay. Sorry, had to read a quick email. So yes, appreciate it. Those are the 2 maneuvers that I'm looking for: is the head tilt, chin lift, and then the jaw thrust. That is the most important. That's the 2 that we can do. Now, again, if you suspect any type of head injuries, don't do that. Don't do the head tilt, the head tilt, chin lift. Just do the jaw thrust. Okay. So be careful about that and make sure that you know what you're doing first. All right. So be careful for the patient. Make sure everything's good. Make sure you do the correct and most appropriate rescue breaths. You don't want to be doing like, okay, we got to do, I don't remember what the chest compressions are. I don't know. So make sure you do the correct, appropriate ventilations and compressions for the age group. Okay, so here you see that they're using a bag valve mask. This one's old. I can tell you that because that's the bag that. So normally there's a little oxygen bag that sits off down here on the end, and it connects into the side of here. And this is called a reservoir. This is part of your ambu bag that the oxygen fills up, and you squeeze and force it down into the upper respiratory system. Okay, and then correct positioning of the hands for the CPR. Good. You're not interlocking your fingers. Make sure that you're going to do correct and appropriate CPR. Now, what I'll tell you is, y'all gonna be tired. These folks gonna be wore out. First off, he wearing long sleeve shirt. You know he gonna sweat. So what we need to make sure to do is that you know that it's time when it's time to change. Just say, hey, changing. I got to take a break. And it's time to change. Make sure you have your equipment. If you don't have all your equipment, make sure it's en route while you're doing your chest compressions. the biggest things I want to make sure. All right, so BLS differs from advanced life support. Advanced entails cardiac monitoring, IV fluids and medications, and advanced airway adjuncts. So to break that down a little bit more, so cardiac monitoring is our 3 lead, which is technically 4. Then we have our 12 leads, which is not 12 leads, but that's the way that they make it. And then we can do a right side of 12 lead, a left side of 12 lead, and then a 15 lead, which is actually technically on the back. Parts of the back, you're moving your other leads around to form those. So we can do that. You can do IV fluids. You can do IM, which is where you screw, where you use the little drill and you screw it into their legs. We can do fluids like that. Now, same thing for advances. Advances can do IVs also. And then you have your advanced airway adjunct. So if I pull up and you have the patient with the oral adjunct in their mouth and it's correctly in there and you're providing correct ventilation, I will not walk up and just pull your basic airway out so I can shove mine in there. Nah, I'm going to prep. I'm going to let you continue doing what you're doing. I'm going to prep my stuff, make sure it's correctly done, and then I'll insert my ET tube as appropriate as needed be. But it's not one of those like, oh, yours is not good enough. That's just not how it works. The patient's being ventilated correctly, so why not leave it? You all are doing a good job. So just make sure. What's this say? Stand by. Let me move this. When done correctly, BLS can maintain life for a short period of time until ALS measures can be started. Great paramedics were good basics. Great basics make good paramedics. So that be the case is, if and when I do work the ambulance, there's only a handful of ladies that I work with. I don't like working with other dudes. It's just a personal thing. There's like 3 girls that I enjoy working with. That's the only ones I work with because they're amazing. They make your job that much easier. You know how like you've got that one coworker at work, you're like, shit, they're not at work today. I don't want to work. That's like having a great partner on the ambulance. They just make it that much easier to want to go to work. Okay, so make sure you're a good basic, because a great basic makes the day go by. And it's fun. Sometimes you get to know your partners. Sorry, y'all. So here's our system components of CPR. For the ones that's had CPR, you should see this. They call it the chains of CPR. Activation of EMS, immediate high quality CPR by standards or by trained. Rapid defib, basic and advanced EMS, ALS, and post-arrest care, and the recovery. So for you to get somebody that's in the cardiac arrest, and then you turn around and if you're able to have that person walk out of the hospital a couple days later, that's pretty jam. I've had some that have made it to the floor, had surgery. I spoke to them and they died due to complications past the surgery. So it is amazing, and we would love to always have those good stories about how EMS responded, did X amount of minutes of CPR and patient walked out of the hospital 4 days later. That's what our goal is, but that doesn't always happen. Unfortunately, the stages of death take place, and there's a lot of times that we just can't do things. But what we rely on is this right here: activation of EMS, immediate high quality CPR. That's why it's great to educate the public in how to do CPR, because there's a lot of folks out there that's just not going to do your job. So it's not like you're trying to train your replacement, nor are they going to turn around and try to be like, oh, I'm going to go to EMT school. There's a lot of people that know CPR because they had to learn it, but they'll never do it. That's it. I got guys out here that they're required to get CPR every year, but they tell me straight up, I'm not doing it if something happens. You on your own. Okay, appreciate it. But that's just part of it. But we rely on these 3 mainly as the fastest that we can get them there. All right, so AHA chain of survival. We talked about that. That is what we just went over on the slides there. Assessing the needs for BLS. Well, I'll tell you this, anytime that a patient calls 911, they're in need of something, some assistance somehow or another. But it's okay to say, hey, this is what we need to, advance this up to ALS care, call for additional units. That's fine. But during this, always assess the needs for BLS. That always is begun by surveying the scene. Start your impressions from dispatch. At the get-go, do you see anything? Do you have anything? Do you need anything? And that's where you go. You'll start there. Complete the primary assessment as soon as possible in order to evaluate the patient's ABCs. Hopefully, y'all have taken my advice and started studying your assessments. And I mean assessments by your National Registered Checkoff skills. Because I can tell you, if we were all in person, you would all know them by now. That would be a graded topic. All right. Sorry, our speakers make a noise. And the first steps in determine unresponsiveness. Unresponsive does not need CPR, but an unresponsive patient may or may not need CPR. You just need to know if they're, one, they could be sleeping. So you don't really want to walk up and kick them, but that's just disrespect. But you need to determine if they really are responsive or they unresponsive. That's important. This step should take no more or no less than 10 seconds. Sorry, my child is messaging me and he's talking about his truck messed up. All right. Basic principles of BLS are the same for infants, children, and adults. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true in infants and children. So why do children go into cardiac arrest over? What is the main cause for children and infants to go into cardiac arrest?
They stop breathing.
Correct. That is mainly they go into respiratory arrest, which causes the cardiac arrest. All right. So how do you check them? You want to check for the responsiveness. That's basically what they want. They want to check for responsive. How do you say, hey, look, listen, feel? You don't really want to startle them, but at this point in time, I don't know why a few minutes ago they were doing CPR on this guy, but I guess they just still now just trying to check if he's responsive or not. Like I told you before, I like to touch them on their forehead, to where if they go to sit up and there's maybe a neck injury, you're preventing that up front. So vital length of chain of survival should be applied to cardiac arrest patients as soon as possible. If you witness a cardiac arrest, apply the AED as soon as available. A lot of places nowadays, AEDs have become a lot more cheaper than what they used to be when they first started. I can remember an AED I helped a company get just to hang on their wall, like we see everywhere else, was $10,000. And that was, they were like, oh, okay, well, that's no big deal. We'll get that one. And I'm like, holy, now you can get them for well under 10 grand. I hadn't priced one in a while, but you can get them well under that. And the faster that you can get CPR or an AED applied to the patient, the better outcome you have. Because if y'all remember the clock, we don't want it to get to 10 minutes or better, because then we know that we're going to lose the patient because it's been greater than 10 minutes and they're already behind the 8 ball because they're suffering for the lack of oxygen. All right, AED in children. Apply after the first 5 cycles of CPR. You can go ahead and put your pads in place, but at the same time as you need to you need to jump start their hearts. So like we need to, let me say this, like a diesel truck, y'all, if y'all don't know, some diesels have to be plugged in. 90% of the diesels have to be plugged in, keep the oil warm. And it's basically like I'm warming the truck up before I go out there and turn the key. Well, that's the same thing for infants. You need to warm their heart up before you just dry stun it with voltage to the heart. I mean, you kind of want to be like, hey, how you doing? Before you just be like, bam, what up? So that's the reason why they tell you to do that in children. Special situations, if you notice a pacemaker, a lot of times they're going to be to the top left shoulder. But at the same time, as you notice on these, you put the pads on the right shoulder and underneath the left area, underneath the left breast area around the side. I don't really know why they always tell us not to put the pads over the implanted defibs and pacemakers, because then they put in a place that you wouldn't ever put these at. So you got to be cautious about that, just in case. Anytime a patient is wet, I'm about to tell you, when I was looking over these slides earlier, I was not in the mindset, and I was reading this, and I was like, wet panties. Oh, never mind. That says patients. My bad. And every time I just looked at it, then I started gagging. I was laughing at myself about that. All right, so you want to make sure the patient's dry. Obvious reasons is you're fixing to put electricity through them, so you don't want to be electrocuted either. I can promise you, I have been shocked by an AED, and that shit hurts. Like, made me stutter. Like, what was that? So make sure they're dry and in a dry area. Now, if you pull them out of the pool, it's okay to dry them off and lay them on a bunch of towels, but you need their skin dry so the water won't go elsewhere and you won't get lit either. Transdermal medical patches. We talked about those other night, so you already have an idea, and I hope you have an idea what the medical patches are. Even nicotine patches, you want to remove those because you're not there. Let me say this: there have been cases that when the patient was shocked, that they had a dump of this medication into their system. I don't really know how that works, because it's not like I'm electrocuting the on button for this patch, because it's a transdermal patch. But that being said, is when you remove the patient's clothes, and if you sorry, not clothes, we don't want y'all to be stripping a patient to do CPR on. But I want y'all to remove their outermost garment for their chest. Make sure you look for the arm on the shoulders and the center and the upper left area of the chest, and make sure there is no patches or transdermal patches on this patient, because it's safer than sorry just to go ahead and remove those. It's the easiest thing to do. Position of a patient. You always want a patient on their back, supine. You don't want to have them on anything. You don't want to be like, oh, well, there's a little ball underneath their left abdomen, it's going to be okay. No, let's try to get them as flat as possible. Because when we go to do this CPR, we want firm resistance when we go to do our compressions, because we don't want anything like if there's a ball or a squishy pad underneath their chest that can, to fight against us from doing correct CPR and ventilations. So if you have to move the patient, but when you do it, make sure you log roll them, so you're not just flopping their head around or taking the chance to hit their heads or anything. But if they're in tight areas, and I can tell you, people don't always have cardiac arrest in the living room. They 99% of the time in the bathroom, right after they've taken a poop or they've eaten greens, and it's never fails. It's small area, and it always stinks. So pull the patient out, and you got plenty of area to work on, and you can do at least 2 people at a time doing CPR, because remember, you're going to have to be suctioning and you can't do it all yourself. As hard as you try, I promise you, you can't work a code by yourself. The ones that say they can, all they're doing is neglecting the patient in some form of fashion. Check for a pulse and see if they're breathing. This is a good time. You can look, listen, and feel. You're checking that cricoid part, that cricoid artery. If y'all don't know where that's at, find the center of your throat. I'll say around the Adam's apple area for you men, and one side to the other. You can go off to the left or the right and start to feel for a pulse. Not real sure why you need 3 fingers right in there, but I mean, hey, maybe they don't feel in the first 2 fingers. So you check there for a pulse. You can also get a pulse. It's easier to check at the radial and work your way up, because if they're in a shock state, maybe the core has already shunted the blood to the core of the body. And the core has already been shunted and we're to receive all the blood, and the pulse may not be there in that distal pulse. So you can always just, as you're doing your assessment, reach for a pulse. You can check it right there at the cricoid, and the better off you are. Rock on. Talk about chest compressions. Applying rhythmic pressure and relaxation to the lower half of the sternum. Compressions squeeze the heart, acting as a pump to circulate the blood. And avoid leaning on the chest in between compression. You want that chest to come to the complete top apex of when it responds from ventilation. You need to have good posture. You will also hurt yourself when you're trying to do this, because you're trying to push so freaking hard and so freaking fast that you're really just hurting the patient because you're not doing adequate CPR. So proper form is the best thing, and hand placement, those are 2 of the bigger parts. Administered chest compressions allow the chest to completely recoil between compressions. Proper hand positioning is crucial. If you don't have them in the right place, say they're interlocked, you may not have a good flat surface, and that's probably why that you're not getting a good relaxation or recoil between the chest. Be careful if you have, what's that saying? Injuries can be minimized by proper techniques. So you can help minimize and breaking of the ribs and the center chest plate by proper hand placement, but don't be surprised if you hear that snap, crackle, pop and ribs are breaking during CPR on some of your elderly and geriatric patients. You may break them also on infants and children, but it's easier to leave the hospital with a few broken ribs than not at all, because you just didn't do good CPR and they died. So there's that. Y'all take a look at that real quick. I ate something sour to try to keep me from yawning, and it's about to kick my teeth in. Whew. All right. So you can see there the heart lies slightly to the left of the middle of the chest, to the sternum and spine. So here's the center part of your chest, that's midline. And as you can see, majority of your heart goes to the left side. So when you go to do CPR, remember, when you go to everybody's like, all right, I'm gonna line up right here in the middle, between their nipples in the middle. Well, let me ask, is this, being honest, folks, is this a male or a female? Because breast placement may not be the same. So make sure when you do that you are anatomically in the center to the left of their chest. Remember that. So when you go to inflate their lungs, remember when you're doing compressions, you're assisting with the compression and the releasing of that diaphragm. So you may have some resistance as you go to do your compressions and your ventilations. So in compressions and relaxations should be rhythmic. The best song to sing in your head during CPR I don't want, and I notice how I said singing it in your head, because staying alive is the best rhythm to use, but it is very, it's most likely traumatizing if you're singing, staying alive, staying alive. That's not, it's not appropriate. So if you do that, please don't break out into your American Idol voice and sing that song. But getting it on a rhythmic timing, that's probably one of the better songs to have out there. And you see when they apply compressions versus when they relax and the hand stays on the sternum and there's not a gap created. But look at the difference in the recoil. You can see that they've given time to recoil and they give time to push again. All right. There's pictures on your head tilt chin lift. This may be some better pictures for y'all to look over on how to do these particular maneuvers. I know there's some questions probably from some that have not been able to do the CPR class as of yet. I can promise you that you will be doing them at your boot camp stations so we can check our boxes and make sure that we know that everybody's done with that. So if you have questions on either one of those, ask your instructor and let them know that you have questions about adding, how to do the head tilt chin lift or the jaw thrust, and they'll teach you pretty freaking fast. You're going to be a hero by the time you leave. Opening the airway. We talked about this as a patient has adequate, if the patient is adequately breathing and there is no signs of injuries to the head, hip, spine, pelvis, and the patient is put the patient in the recovery position. And this helps maintain and with a clear airway, allows vomit to drain out of the mouth, and it rolls the patient as a unit. Does anybody remember what side you're on if you're in the recovery position?
Left side.
Left side.
Good job, y'all. Good job. You're going to be on your left side. It is also called the left lateral recumbent position. Don't ask me to spell. Y'all know I can't spell. So it's left lateral recumbent position. That's what it's also known as. But here it is right here. The left leg is straight out. The right is pulled up a little bit. The left arm, most of the time, is straight out from them. But depending upon space, you could move a little bit. And then they are laying on their right hand. So it's hard for them to roll backwards. And they're not going to roll on their face. I can promise you, unless they are conscious and they're faking, that's the only time that they will roll on their face. The combination of lack of oxygen and too much carbon dioxide in the blood pressure, and the blood is lethal. Geez, I cannot read tonight, y'all. If the patient is not breathing, ventilations can be given by 1 or 2 EMS providers. And remember, just because you pull out the bag valve mask, if y'all are ever out and you work on a standby, and it may just be like standby at a petting zoo or the local fair or something, and they just got one person there, and they call you over because there's a guy that has gone into cardiac arrest. You can do the 1-person CPR. You're gonna be a tired fool when it's over, though. But that being the case, is you already know the maneuvers. Do I do 30 compressions in 2 breaths, or is it 2 breaths and 30 compressions? You always want to do at least 2 rescue breaths and then start your compressions, because what it does is it gives that person a chance to go and they can start breathing but be unresponsive. So if you can stimulate them in some form of fashion, that would be awesome, because then when you start doing your chest compressions, if they start breathing, you don't really have to do a chest compressions mode. But when you are doing chest compressions and they are unresponsive and the respiratory failure, you already know that you've got airway. You can give a non-resistance bag because you've already done it, and you didn't really have to move them a whole lot. Provide slow, deliberate ventilations that last 1 second. If the patient is not breathing, ventilations can be given for 1 or 2 mask providers. Again, use a barrier device such as a pocket mask, one-way valve, or a bag valve mask. I am not getting my face that close to them. I don't care. Unless it's my child that I helped make, I would probably do a mouth-to-mouth in. But I don't even know if I'd do that to a good friend. That is just, it's gross. I mean, no thanks. All right, so again, we talked about the EC method. Here's a picture of it. You want to make sure, and if you notice, she's also in the head tilt chin lift, because that's also called the sniffing position, because it looks like they're sniffing. You feeling me? You understand that? So you see, he's actually got another finger that's right down here. There's a finger right there on the bottom of the jaw. These top 2 fingers are holding this mask in place, and then he's ventilating by pushing the bag on this hand. So it's easier to use your dominant hand on the mask versus the dominant hand on the bag, because you just feel like you're in more control. And the seal is the important thing, because you need all of that bag to be delivered to your unresponsive patient. So the better off that you can ventilate them by making a good seal, the better off you are in the long run is helping them survive. So here we go again. We're talking about stomas. Here's a picture. So that's actually a corpse, not a patient. So with a stoma, you can actually keep the stoma in place, but you can also take it out, suction the hole, and put your pediatric bag valve mask over the wound and breathe for them through their stoma. It's gross. I'm just gonna let y'all know, because it's all like it's got nastiness in it. So I don't like them at all. But there's a good picture. It is, if you can find a cool person that has a stoma and they can educate you a little bit about it, the better off you are. But I don't want this to sound ugly. I just haven't been that much of a go-getter to do that because they're gross. But it is very smart to do that. Single rescuer CPR should give a ventilations and compressions of 30 to 2. I bet you that's gonna be a test question. Always perform one, always preferable, the one rescue CPR, the less tiring. We know that. Switching rescuers during CPR is critical to the main high compressions. Recommend to swap positions every 2 minutes. That's a test question. So I would make sure you're changing out every 2 minutes. And most of the time, by the time you do 2 rounds of CPR, and then you turn around and do 4 ventilations, so 60 compressions and 4 ventilations, it's time to swap. But if you ain't got nobody, time to put that in Superman mode and get that done. So you have active compression, some decompression CPR, and involves compressing the chest and the activities of pulling it back up to its neutral position. This involves compressing the chest, and then the activity pulling it back up to the neutral position may increase the amount of blood that returns to the heart. And the impedance threshold device, I have no idea what an ITD is. I know what a UTI is, but not an ITD. And this is designed to limit the air entering the lungs during the recoil phase. Not sure what that is. This is kind of like your CPR device that automatically does the compressions for you. I don't really know what that one's called, but Zoll has one. It's called the Lucas device. Theirs is really, really cool. I've used theirs, unfortunately, multiple times, and I like the Lucas device. So an impedance device is, what it's trying to do is it's letting the lungs exhale completely before it allows lungs back in there, air back into their lungs. And also another tidbit here, On this bag valve mask, if there is anything called a PEEP device, well, the PEEP, what it does is it only allows you to ventilate the selected age, which means adult, child, and infant. If you squeeze that bag too hard, you will notice this little PEEP valve over here will push all the air out. So if they're being overly forcefully ventilated, that PEEP valve is going to divert all the air that way. But if you do your normal bagging of the patient, all the air is going to go straight down the lungs because that's where it's required to go, and it keeps you from over ventilating. Some agencies have those built into their bags. Some buy them in separate devices. They're expensive no matter what, but that's some of the things I've seen in the past. Mechanical piston device, we talked about that. That's it can be electric. Here's one right here. That is a load board. Basically, you put the patient on a half board, strap the chest stuff over the strap over the chest. The arms go on the outside of this, and then you pull it tight. You hit the start button, and it's like, and then you gotta stop and breathe them. When it's time to do ventilations, it'll say provide ventilations. So the Lucas device is also kind of set in the same way, but it is a electronic device that's driven. I also have in the same standard, I've had a Lucas device crack a man's chest, and he died, but thank God it wasn't because of me. But those Lucas devices can also be very traumatic to some family member that's never seen them before. You don't want to use Lucas devices or anything like that on any child under the age of 17, just because of the pressure it uses. In most child CPR, most cases, cardiac arrest follows respiratory arrest, like we talked about a while ago. And this triggers hypoxia and ischemia of the heart. So we know why that they went into failure, but we know the most common reason. How about that? Airway and breathing are the focus of pediatric patients. You always, a crying baby means a healthy baby. I know that's not necessarily the term, but a quiet baby is the one that you need to worry about. Because babies around strangers, you know, or y'all been around family members that the babies are like, I don't know about this dude when they're little. It's the same thing. But if a quiet baby comes to you, you want to take suspicion depending on why you're called there. Cause of respiratory problems, injury, infections, foreign bodies, submersions, electrocutions, poisons, overdose, and SIDS. Can somebody tell me what is the record of a submersion, cold water submersion drowning? What is the longest time that somebody has been down and under and back resuscitated? Six hours. So you have to be warm and pink, warm, and dry to be pronounced dead. Now, granted, I know if they have other signs of immediate death like rigor mortis or pooling of the blood, that you can be cold and dead too. But from a drowning standpoint, you have to be dry, warm, and pink. That's kind of the standards. There's not much anything we can do for SIDS. I don't know. I'm sure if somebody's at least heard of it in your community, if not, y'all have dealt with it firsthand. But that's a big point. Electrocutions, man, you know those little turds stick their fingers and tools and toys in every little hole. So do some prep work when it's yours and you're bringing that little turd home. Submersions or drowning, foreign bodies, they put that shit in their mouth all the time too. They're like, quit putting that in your mouth. So you're gonna have foreign bodies, infections, because they won't keep the crap out their mouth, or their white blood cell count is high and they just don't have the go-go juice to fight it any longer. That's all that they got. They're giving you all they got. And then any type of traumatic injury, it's going to create a respiratory issue, a sickness. So those are your top 7 issues that you may come across. Determine unresponsiveness. Like I told you earlier, you want to tap the child on the shoulder. Maybe you can tap them on their feet. That's cool. If you find an unresponsive apneic pulseless child while alone and off duty, perform CPR for 5 seconds, 5 cycles, about 2 minutes, and then call for EMS. Remember how I tell you, you got to get that body warmed up and get going. You're gonna get that motor start to try to turning again. Maybe you can get it to turn over, but you need to do your 5 cycles, call for EMS, and then get the AED. Check for breathing in the pulse. Capital or brachial arteries in infants is probably going to be your best place to check. Radial pulses get stronger and more predominant the older that this infant gets, so you may not feel one. You only want to use the 2-finger method in the infant's chest, so be cautious for that. If 2 rescuers are performing CPR on an infant, use the 2-thumb in-circulating technique to deliver chest compressions. Basically, what you want to do is you want to squeeze their body, the fingers interlock with each other on the child's back, and you do CPR with the thumbs. I think there's a picture of that later on too. On the airway, if you see anything, remove it. If the family tells you he swallowed a quarter and now he's unresponsive, well, you can pretty much bet you that the quarter caused the airway distress, and if they die, it's due to a foreign body obstruction. But side note, if they got COVID, they died of COVID, not the quarter that's blocking the entire airway. Sorry, I thought that was just funny. I had to say that. All right. So another thing with kids, you want to place wedges underneath their shoulders. What that does is it gives them that anatomic automatic position all the time for the sniffing position. So if you can pad their shoulders with like a rolled up towel, anything like that, their head will 90% of the time automatically just drop back into the anatomic sniffing position. So just a little trick there. Back onto your CPR again. Provide rescue breathing, 1 breath every 2 to 3 seconds. If they're not breathing and no pulse, you want to do 2 breaths after every 30 compressions. 30 to 2, 30 to 2. It hasn't changed yet. I remember when it used to be 15 to 2. I'm showing my age, but just note that it's about every 10 years is when they try to change it. So it may be close to time for them to do anything. A face mask with a 1-way valve or other barrier devices over the tracheostomy site can be used. So if a kid is sick and they have a trach tube, a J tube, or I forgot the other one, you can use that 1-way valve or a pocket mask. That's the most appropriate size for their body size. I'm gonna hit these next 2 slides and we'll take a break. CPR is crucial to life-saving procedure. We know that. We're pretty sure that's been beat on us since we were like, what, 8 years old? If there's no ALS available, please transport per local protocols and consider requesting ALS to rendezvous while en route to the hospital. Some places, I want to say LA County has a procedure. They activated it during the first phase of COVID, is that it is any respiratory arrest was an automatic, any cardiac arrest and respiratory failure was an automatic call on scene and no transport, because there was no facilities that would take them because they were full. Try not to interrupt CPR only for a few seconds, especially when you're doing your changing the personnel. Try your best to only interrupt for less than 10 seconds. What I like to say is when you know it's time to do to swap, take a deep breath. When it's time for you to breathe again, you know it is past time to start breathing for that patient. Total percentage of time resuscitation attempt of the chest compression to be formed should be at least 60%. To maintain chest compression fraction greater than 80, that helps you minimize your time. So if you want to keep that compression fraction around 80%, decrease the time that is paused between swapping a person out. All right, I'm gonna give y'all, this chapter is super short. We're on 45. We probably got another 20 slides. So when we come back, we'll probably finish that up pretty quick. All right, give y'all 10 minutes. See y'all back in 10. All right, I'm back. Hope everybody's back. I know y'all missed it. Oh, where did the button go? All right, let's see here. So somebody, and we probably haven't got to it yet. Somebody tell me what the compression rates are for adult and infants.
30 for adults. 15 for infants.
There's 30 to 2, 15 to 2. That is correct.
Are we talking one or two rescuer?
Well, it should be the same, right? Or are we wrong?
No, it's not. According to AHA,
There we go.
if you have two rescuers, it's 30 to 2 in a infant.
There we go. I was trying to trick you guys. So you got to make sure that you do your proper compressions of the age group. Now, are you going to get confused on your first cardiac arrest? Heck yeah, you are. Are you going to be like, oh my God, I don't know what I'm doing? Bet so. So it's okay to question it, but make sure you know, again, like somebody asked the other night about cheat sheets and all that, because you have time when you're responding to a call, well, unless you're driving, to look at your notes, look at your cheat sheet, make sure you understand what the protocols say that you're allowed to do. So sometimes it's okay to be like, I don't know everything. I don't know every drug in the world, but I got a phone that does, but I won't Google it. I'll do it right in front of a patient. I ain't hurt my feelings. You don't see Dr. Wally, you see Medic Wally. So there's a big difference there. So yeah, make sure that you know your AHA guidelines, you know what your compressions are, and your protocols are super duper important. When not to start CPR. When is it time to be like, no? It's okay to say no. So if the scene is not safe, you should not be there. You should just grab your shit or either leave your shit and just leave. Go on. Bye-bye. See you later. If the patient has obvious signs of death, we have rigor mortis, dependent lividity, perfraction of a decomposing body, and evidence of non-survivable. So if you have rigor mortis and the stiffening, obviously the evidence of non-survivable is probably the ones that you have the question about the most. If their head is missing, if they're cut in half, if they have brain matter that is showing, hey boys, I don't know, and girls, I don't know if y'all need to know that, but they're not gonna live. I'm just gonna tell y'all, they ain't gonna make it. They may be wiggling and talking just a little bit, but guess what? They not coming back. They done. Okay, I'm sorry. That's when not to start CPR. So here's a picture of dependent lividity. So all that is that's pulling. Well, basically, you see the hand right there on the back. What the hand was is probably pushing the patient over to the side. What that is pictures of blood that's pooling in the body. It looks like a really bad bruise, but I promise you, they not gonna heal up from that. I'm not trying to make fun of it or jokes, but you need to, if you see that and the corpse is stiff, maybe rigor mortis has let go and started to decomp, and it's been greater than 6 hours, that you may only see, the lividity versus the rigor mortis. Come on, next. If the patient and physician have previously agreed on the do not resuscitate orders, and again, so you need to know your state laws on that, and it's always okay, even if you get a patient that you have questions, let's say the family's not in agreement or there's a bickering going on, call the doctor to be like, hey bro, that's a question for you. We're here at such and such with such and such call, and here's the situation. I need some advice. They can help you with making a decision. Once you begin CPR, you have to continue until the patient starts breathing and has a pulse. Patient is transferred to another provider, equal or higher level of training. You are just wore out and out of strength, or the physician tells you do not begin again. Now, it can be, you can call and be like, Doc, man, we have been working this code for 30 minutes and it's just a BLS truck. We've tried everything we can and we can't load the patient to leave because of such and such, or blah, blah, blah. Give them the scenario and they may give you orders to terminate CPR efforts. Now, it is hard the very first time to walk in there and be like, listen, Miss Fred, we've done everything we can do for the last 30 minutes. Mr. Fred ain't coming back. We've tried everything. We spoke to our doctor and he has told us that we can stop doing CPR. I just want you to understand what's going on. And when you transfer a patient to a higher level of care, hopefully it's to another ALS unit or an ALS unit, just maybe a helicopter, ground ambulance, or something like that, to a higher level of care. Airway obstructions may be caused by relaxation of the throat muscles. 90% of the time it's vomited or regurgitated stomach contents. Oh, gotta do the suction again. I can smell it now just talking about it. Oh. So you can have an upper GI bleed where they vomit the grainy looking coffee-like substance and it has blood in it. It is super, super dark and it smells horrible. Damaged tissue can be throat particles. It can be part of some foreign debris that's got stuck up in there. And we talked about foreign bodies down there. And then it hits dentures. If there's a massive trauma to the face and the dentures go into the airway and parts of the teeth are broken from the dentures itself, that can cause airway obstructions. Got to get that out. We got to do the best we can. And this way we can do it. In adults, it usually occurs during a meal. In children, airway obstructions usually occur during a meal or at playtime. Mid-airway obstructions, patient is able to exchange adequate amounts of air but still has signs of respiratory distress because the patient has not worn out of oxygen yet, so they're still running off that reserve. So this leaves the patient alone, observe for signs of severe airway obstruction. So maybe if you're like, hey, my name's Wally, can I help you? You may be able to provide a non-rebreather. You may be able to provide, kind of get the picture, a Heimlich maneuver, and that can help relieve those. I want to go back one. Sudden severe obstructions is usually the easiest and recognized to get out of the airway. Some that do not, when people were like, oh, I was by myself and I did the Heimlich maneuver myself. Man, I ain't got enough guts to do that to myself. I'm just going to tell you that. That sucks. Having to lean over a chair and try to make yourself cough up. Nah, bro, that sounds difficult. So abdominal thrust, the Heimlich is recommended in responsive adults and children than 1 year. Here's your picture if y'all don't know the abdominal thrust or the Heimlich maneuver. You want to make sure when you stand behind them that you do have a firm footing, because there may be times once that patient goes unresponsive that they will drop due to their weight, and you need to make sure that you are able to support that. Instead of abdominal thrust, use chest thrust for some of the following. When you have pregnant women or obese patients that you may not just be able to fit your arms around, you want to go with or Tamara saying she had to do this thrust. It sucks. I guarantee it's scary. I've never had the ability to do it to somebody. I've always got in the position to do it and they comes it up on their own. So, but on the pregnant ladies, you want to go on top of the breast this time instead of between the breast and the stomach. Now I'm gonna tell you, there's probably going to be some discomfort, especially if they're that far along and their mammary glands are starting to produce and store milk. They not gonna like you. But again, you're gonna be like, well, you can thank me or you can die, but I would rather you thank me. So it's okay for your chest to be a little sore. Those are just the big things on pregnancies to be careful. Your proper hand placement may be, and if you have to do um, I just went blank, the abdominal thrust on obese patients, you may have to do that because you can't reach your arms around them. So that may be something you consider. Unresponsive patients, again, we need to check to see if they're responsive or not. And the only way to do that is basically poke them, touch them, and talk to them. Make sure that they understand. Check for pulse. You can do radial, brachial, carotid pulse. It shows, sorry, I wasn't even looking at the screen. It shows that you need to do 2 rescue breaths anytime that you begin your CPR, unless you know and you witness them take their last gulp of air. No matter what, if you walk up on them, at least give them 2 rescue breaths. Again, if we can stimulate their body to go into that auto drive, breathing for itself again, or you may realize that 2 rescue breaths is time to start CPR. Was the attempt to carefully remove any visible objects. That again, let's be cautious because if let's say we get them to tilt over to one side or the other and it falls into the cheek, be cautious about sticking your fingers into there because if you stick your fingers into the cheek, they can easily bite your fingers. I mean, you know, you've all at least stuck your fingers into a dog's mouth or an animal's mouth, and if it's in their cheeks open a lot further back, but they can still bite you. So it's the same thing for adult or a child. So just be cautious of that, and if they are forceful biters, they could potentially bite your fingers off. Some foreign body of airway obstructions again. Going over it, that is a very, very common problem. We do have that happen a lot in the children because they stick every single thing into their mouth. So you have to be careful about these obstructions. Unresponsive standing children perform the Heimlich maneuver. If the child is unresponsive and greater than 1 year, is managed the same maneuver as an adult. Here's another one. Oh, come on. Let me hit my red button. Go. So here you notice how the young lady, she's standing behind the child. She's down to his level. We don't want to pick them up and squeeze them because they're a lot shorter. So when you go to let them go, they're going to fall. So get to their level when you go to do this Heimlich maneuver. It's because also, again, if they go unresponsive, you're able to hold them and catch them and support their heads on the way to the ground. Infants and children do not use abdominal thrust. Perform back slats and chest thrust, which are compressions. Bam, there's you a picture. That baby is pissed off taking this picture. I can tell y'all, I looked at it earlier and I was like, that's probably the worst picture of the whole slideshow. That baby is not happy. But you really want to basically give that thrust as in a back pat. You want to do it in a diagonal method to where you're hitting the back and kind of going towards the head because you're trying to create the pressure change in the chest cavity to make the air potentially push out whatever it has to. When you flip that child over, if you'll notice how they've got them sitting right here, if you're having to do compressions, the best way that you can do it is this leg goes between the body and your arm, and this leg goes on the outside. So you're basically securing that baby to your arm. Miss Rebecca says, I had to do this with 2 of my kids when they were less than 1 year old. Miss Rebecca, was it because of food or did they just eat too much and eat fast?
It was food. It's usually the older sibling sticks a piece of candy in there or something. And of course they can't eat it because they have no teeth.
Yep, that is a lot of times we will see the same thing in infants that they call you like, oh, my baby's quit breathing, they turn blue. Well, yeah, but that's because they were choking and maybe forcefully they were trying to take the bottle down, or they maybe have gulped too much and then they and the milk came out their nose. That's kind of like us. Food and water will come out of our nose. I promise you, it's not comfortable. So that is possible, and it does suck to do CPR on a child. It does suck to respond to that pediatric cardiac arrest. It does suck to go to that SIDS call, but it's unfortunately too common. It is too common for us than we really realize, and it takes a toll on you. What's up, girl? How you doing? Hey, I can see her. I was talking to you. So it's uncommon when we have those, and they are repetitive. We worry about mental health, EMS mental health. It does have issues to where you have to take care of yourself. But back to this picture, sorry, sidetracked. My bad, brain fart. So when you go to hold this baby and when you flip them back over, you just have to be careful when you're flipping them from the chest compressions to the back blows, because you're gonna have the legs interlocked between your arms and your body. And it is really important, because I promise you, when it is time to move and you're ready to go to the ambulance unit, make sure you have a grasp of that baby. It don't matter what happens, just hold on to that baby. If you hold it in a normal position and you're trying to get some younger, don't be afraid. If you accidentally, you hold it in like a football and do the Heisman maneuver as you're moving, because it is better off to secure that baby. I've seen some people put them on stretchers and move them out. You're not gonna leave that baby on the stretcher. It's easier to hold them in their arms and go to the unit. La la la. Foreign bodies in infants. We'll talk about this. Let's see. In infants, never check for compressions. Shoots. Let me start over. Never check for a pulse first. Always start compressions. It's not gonna hurt their little bodies. Most of the time, if I have a baby that doesn't have any teeth or anything like that, I'm going in if I see something in their mouth. It's not gonna bother me. It is very much something that I can reach my finger in there, potentially move it out. But you just do make the little form hook in your fingers, and you try to just drag it out to their cheeks, and then you can roll them over to their face down, and hopefully it'll fall out. Resume chest compressions if no object is seen. Continue the sequence of chest compressions, opening the airway, and look inside the mouth until the obstruction is relieved or somebody shows up to take over. But what sucks is that when nobody takes over and it's all on you, you're just like, I'm so wore out because there's nobody else. So be cautious. Make sure you have enough support coming or you need extra help. Special resuscitations and circumstances, opioids. Oh, God, come on. Opioid overdose. You have your standard resuscitation measures. We talked about naloxone. We talked about other things that we can use during the process. Cardiac arrest in pregnancies is never, ever, ever easy. It is a very hard situation because it is unfortunately a 2-for-1 situation. Priorities are to provide high quality CPR and relieve pressure off the aorta and the vena cava, because it's got to get blood to that baby. If the pregnant patient is not in cardiac arrest, then position her on her left side to relieve pressure off the greater vessels. That is the recovery position also for the females that are pregnant. If she is in cardiac arrest and the top of the patient's uterus can be felt at or above the level of the umbilicus, perform. Hold on. Let me read this again. Never mind. I'm not gonna read that because that is very deep. Whoever's looked at the slides or anything like that, y'all looking at it now. I don't like number 3, so I'm not gonna go over that. If y'all can read that, so I'm just gonna leave that out. I do not like the sound of that one. So here we talked about it. Family members may experience a psychological crisis that turns into a medical crisis. Yes, and yes, that is the best way to put that. Family members of loved ones will remember this event in detail for the rest of their lives. It is the same thing I tell people, that if you go to the home of a patient, and it's found by one family member to be deceased, and the family wants to go in there and see their loved ones, you can't stop them. You're not law enforcement, but you can tell them, hey, listen, I know it's not my place, not my time, but I just would like to say something to you. It's always best to remember family when they were alive, willing and caringly, and they were in their normal. What state that Fred is in at this particular time is not something that you want to see nor remember from this point forward. So try to give the family an understanding and an idea that you're giving them a warning, but if they go in there, that's on them. I was blessed. I've seen a lot of people in my career pass away. I was blessed to be very close to my mother's side when she passed. It was spent a lot of time in it, but it's hard. So then when the next time I went to someone that had passed because of a cancer thing or a situation, I tried to remind that family, let's be cautious, because we know that what's going on is not what we want to remember. So it is scary. So give the family some respect as you go through there. Give them some education, and be considerate, but be concise and clear about things. Let's be very honest. Don't be like, well, is Fred gonna make it? Ma'am, I'm gonna do everything in my powers I can do for Fred at this time. It's not looking good, but I'm gonna get in there and do the best. But I just wanted to let you know where we were. It's easier to be honest than to lie about him. Be like, oh yeah, he's gonna walk out here in a minute. No, he ain't, because the coroner gonna come carry him out of here. After resuscitation is stopped, helpful measures include take the family to a quiet place. You may have to introduce yourself again. The family may know you. Don't ever use, well, honey, that was sweetheart in there on the floor. No, try to use their name. If you're not a confronting person, don't try to do this. It is very hard to get in there and allow somebody to talk to somebody about this when it's you've never done it. It's very hard to do that. So doing it the first time is the hardest part. So it gets easier over time. Unfortunately, that's part of our job and our career paths. But passing on a bad news is not the easiest. And I have before written on my glove the patient's name. So when I went in there to talk to him, if I went blank of Fred's name, I could look at my glove and be like, oh, thank God, there it is. I see it. Ooh, okay, I can call him by name on cheat sheets. After resuscitation stops, helpful measures include expect motion, be supportive, do not hover. Ask if a friend or family can be called to assist. Ensure that children are not ignored. They also deserve the same respect. You may have to answer a few more questions, or they may be more withdrawn, and that is expected of the situation. But be cautious of what you say in front of these little ones, because they remember a whole lot more than what we think they do, and they don't forget. The reason why I became a paramedic is when I was a young child, my mom was super allergic to any type of iodine, seafood, iodine, salt, anything. Well, she had a reaction to some iodine, and the paramedic came and saved her life. And I never forgot that. He took the time to talk to me in the ambulance after at the hospital. He just took the time, and I've never forgotten that since then. And that's why I love doing education, because it's not what I know, it's what I've been through and what I can teach others. Our field of work is not going away. So take the time to learn, and how to educate is the best part. It's hard to figure out how to teach you guys and add some extra information in there when I can't see you, I can't, interact with you, we can't go, hands-on skills. So doing of interaction of skills and all that does get difficult, and you could tailor a class around your people, but again, as I don't one-on-one know you like I would in an original class setting. So this has been difficult the last few classes that I've taught, trying to get through this and teach online. CPR skills do deteriorate over time. I promise you, you don't use it, you lose it. But if you work on an ambulance, fire department, volunteer, you don't forget how to use it, because unfortunately you use it a lot. Same thing with Miss Rebecca. I know, I'm pretty sure you do it in the vet. So it's CPR is CPR. When somebody passes, it's hard. I mean, it's one of those and especially when those puppies, whoo, can't do animals. That's really all I'm gonna say about that. You are a huge advocate of your patient. You are looked at to answer a lot of the whys of EMS. Why did this happen? Hell, I don't know. I just got on the truck and they sent me here. No, that's not the answer. Don't do that. Be compassionate. You know, Miss Fred, I'm sorry. I do not have the answer for that, but that is a very valid question that you could ask somebody. Would you like me to reach out to a friend or a pastor of your church, or is there anything that anybody I can call? And a lot of your elderly just don't have anybody, and it's okay to ask the police officers that are there, because it's become a crime scene at that point, if they can call their chaplain with their service, with the police department, because this elderly lady may not drive and she just doesn't go to church because she doesn't drive. So that could be very beneficial too. Unfortunately, in the EMS state that we are in these days, we don't have a lot of time to sit around and be that compassionate person with the family, because there's always 9,000 EMS calls holding. It doesn't matter if you stop for lunch, dinner, or you just got to go to the bathroom. They still there. So I hope majority of you have had CPR. Should be just a refresher, kind of breaking in to get some of the certifications. That's really it for the night. Does anyone have questions? Want to go over anything? I know you're fishing to go to your boot camp this weekend, if I'm not mistaken. Is that right? Am I right on things?
Yeah.
So I wish you all the utmost bestest at your boot camp. I do hope in time that I can see some of you guys, meet you. I still never once was able to meet my last EMT class. One day I'm gonna get to meet some of my students. Do y'all have any questions that I could potentially answer? Do y'all have any, want to go over anything? I mean, we've got plenty of time to go over things. Has anybody got anything y'all want to go over?
I
This
just
is
have a
y'all's
question
money.
about the FISDAP thing on Navigate. Do I need to ask Robert?
Well, Navigate, Rob and I got thrown into FISDAP recently.
Because
I don't have an answer for you because I've never played with FISDAP.
okay, because it's asking for another code, and I'm like, I don't know. And I contacted I contacted the ambulance service to schedule my first ride along, and they are familiar with FISDAP, and so I'm just like, I don't know what I need to do on my end and how to get the stuff
think
to them.
Rob is going to turn you on to Miss Donna. Stand by. Let me check our chats on who does what. So Donna, what is Donna's name? So in your group, and the group, whatever app this is we talk on, it's at Donna. It's Donna. She's our clinical coordinator. She is in the I think she's in our class. If you tag her and she doesn't answer, I'll make sure to add her. But super cool lady. She'll answer that. I know that y'all were probably already in class because I was in the wrong class. And I know we said we'd talk about it tonight. I jumped the gun on sending y'all the email about the navigate. I thought everything was situated and ready, but I missed an email, and Rob called me right after, and he was like, "Hey, bro, you a little trigger happy on that on that email?" I was like, "Uh-oh." So that being said, is I have to get you another set of 10-digit codes before y'all can get into the navigate. So go ahead and take your test tonight in the regular class. I'll try to go into navigate and unlock it while I got y'all. I'm gonna work on trying to change that so I can change your test pattern for y'all tonight, because I actually found an easier way to unlock that. But from now on, and the reason why we want everybody to change over is because we now own the navigate, the app that we're using, because the one we had before, we didn't have all the good, we kept having difficulties and all that with, is because one of our other employees had the codes, they owned it. Well, we didn't own the program, so now we do. That's why we want y'all to swap over. Well, I can't get it done that fast. I'll get it done in a minute. So give me a little bit. I'll move the class up till 8 o'clock so y'all can take your test. So y'all can get an early night off. Is there anything else I can help you guys with? This is y'all's time. We've still got plenty of time if y'all want to go over
Hey,
anything
Chris.
else.
You
Yeah.
said we're going to take the test like we normally have been. I don't see an email, so I have no idea what you're talking about.
Okay. All right. So right now, when you log into Navigate, you normally see where it says instructor Krista. Well, she's the one that has owned that before. So we had some difficulties. I didn't have the access that I needed. I couldn't go in there. And let's say if Joseph, if I needed to drop you out of the program, I didn't have that ability. Well, within that, when Miss Krista departed from the company, we weren't given that access. So we had to take some time, and finally we own the program. We own our own program. Rob's the holder of it. Under the new code that I sent y'all, once I hand out, I will individually email you your 10-digit codes and the course ID. Now we own every bit of it. So if I want to make Joseph the instructor for class tonight, I can give you all the rights. I can give you everything. If I need to drop you, I can drop you. So that's the only reason why we're changing. I will manually input everybody's grades over. Oh my God, that's a lot. But I will manually move everybody's over. There's no way to copy and paste that. So that's why that's that email that you missed. So please just bear with me. I apologize. I sent misinformation out too early. I was trying to be an overachiever, and I was not an overachiever.
Okay, so for now, just continue like we've been doing, and we'll get another email later.
Please, I will have that fixed by I will have that fixed at the latest next Thursday, because I travel home Tuesday. So Tuesday for me is literally flying, traveling, driving home, open the computer up and be like, oh, what the hell are we talking about tonight? Because I don't know what class is about. Because it's literally a 4-hour drive from my heliport. So, but hopefully I can have it done by then and have it all emailed out to y'all. But until further notice, just continue using the same way that y'all been doing. This is what everybody's been, oh, come on. This is what everybody's been waiting for tonight. There's your class code. Please make sure you write that down, because that is the way that is a 0, not an O. That is 0, money sign, capital X, capital T, capital Y. I don't know where some of these codes come from. I just literally do randomizer and they pop up. Hey, I got your email earlier. Come on.
Okay. So do we this weekend I guess I might be one of the few that already has his BLS. Do we bring our BLS certification with us too as well when we go to training?
Please, that would be very, yep. So here's the thing, you can actually sit and get a new one if it's close enough for renewal. You can get a renewal card and you can move forth from that, or you can just get a research, or you can just get more hands-on training. I understand you work for a pretty big service, and I'm glad that you're moving on through this to come through the EMT school. Thank you for doing that. But we have to offer it for everybody because it's included in the group. And since it is boot camp, you got to have your CPR to get on an ambulance. So that's the reason why we offer it that way.
I appreciate it. I might, even though I've been pumping on some chest these last 2 days, but I might just get up in there this weekend.
All right. So, and listen, to answer your question. So the question he asked in email is, when you go to these boot camps, what is the attire? I'm not asking you to wear Sunday attire, shirt, tie, or full length. I'm not. But what I need you to do is don't show up in no booty shorts. Don't do it. Not gonna happen. You will be asked to leave. Period. I know, Joseph, I'm sorry, bro. I know that was your plan to wear some coach's shorts. I'm sorry, but no, please don't do that. And it's because we will ask your permission to use pictures, and we can put on our sites and other publicity to push out there. We want you to be professional. Wear something that you wouldn't mind your grandmother seeing on the front page of the paper. Does that make sense? That's really all we ask. Anything else, anybody? Good luck to y'all at boot camp. Have a fantastic night, and I will see y'all Tuesday. I will be at home, so I'll be there. We'll be ready to roll. Have a wonderful night, and peace out to y'all. I will see y'all Tuesday. If y'all need something, please, please, please email me, contact me, Discord me, hit me up. I'll answer you, maybe in some time, but we'll get you taken care of.
All
Hey,
right,
is
thank-
there a module test tonight and the chapter quiz review thing?
So the module has, well, I don't know, you can take that, it's open. And there is a quiz on this. It's simple, it's very quick and easy, like your regular 10 questions. So your module is open. I don't know how many days it's open for. I'd have to look back in my Navigate, but the module is open. So you can take both of those, or you can take just one and push the other one until tomorrow night.
the module is open till Friday night at 11:59.
Now, I will tell you, be careful, because Navigate will not allow you to take it if you log in super late. So if you log in at like 11:35, it ain't gonna let you, because you're not gonna get done in time. So you will get a 0 for that. All right, if that's it, I'm gonna let y'all bounce. I'm gonna turn the cameras off, sit back here for a little bit. Y'all ask me any questions, or y'all can get my attention, and we'll take care of y'all. If not, have a wonderful evening and good night to y'all.